Good morning, good afternoon, and good evening, everybody. I'm Benedict Walter from the Secretariat of the Network for Improving Quality of Care for Maternal, Newborn, and Child Health. Welcome to this webinar on health worker perspective, challenge and solutions, which is the fifth webinar in a series on delivering quality essential maternal, newborn, and child health services in the time of COVID-19. This series is co-hosted by the Network for Improving Quality of Care for MNCH and the Quality of Care subgroup of the Child Health Task Force, with the support of UNICEF and the World Health Organization. Today, we have 3 speakers for you for about half an hour of presentations, followed by half an hour of question and answers. Please type your question in the chat box, addressed to all panelists. And if you can specify who you are directing your question to, that would be very helpful. And while the speakers are presenting, type your question and we'll read them out in the second half of the webinar for the speakers to have a chance to answer you. You will see that you're all muted, so everything will take place in the chat box. We also invite you to continue this conversation after this webinar. If there are more questions you would like to ask our panelists today, you can post them in our committee of practice, and you will see the link further on this morning. Please now welcome our speakers. We have 3 speakers, as I said, and the panelists will be introduced this morning by Dr. Tedbab Degefi Gabriel, a senior advisor for maternal, newborn, and child health in UNICEF, who is one of our moderators. Tedbab.
Thank you, Benny, and dear colleagues, welcome. Good morning, good afternoon, and we are excited that you could join us. As Benny said, this webinar series is looking into maintaining essential health services for maternal, newborn, adolescent health, and quality is crucial, as we all know. First and foremost, quality of care is important to avert healthcare acquired infections in the time of COVID. And second of all, quality of care is important to ensure positive health outcome for patients coming to our facility. And quality defined as by WHO, as you can see on the slide, looks into all these domains. And as we know, these are COVID poses a huge threat on compromising these domains. Next slide. And the objective of this series is twofold. First, we wanted to highlight the need and also the opportunities to maintain and strengthen maternal, newborn, pediatric quality of care, especially in the context of the pandemic. And second, we wanted to have this platform to share global guidance and learn from countries on approaches that they have used to maintain quality essential services despite the pandemic. Next slide. And as Benny said, this is the 5th webinar series, and it will be looking at the health workers' perspective, challenges, and solutions. I will be one of your facilitators, joined by my dear colleague, Dr. Blerta Maliki from WHO. And today we have 3 esteemed speakers who would be talking to us in this really timely and crucial topic. Dr. Lenka Benova from Institute of Tropical Medicine, Antwerp. She will be speaking on the findings from the recent Voices from the Frontline survey, documenting experiences of frontline maternal newborn healthcare providers. And then this will be followed by experience from midwives in Malawi by Dr. Andrew Lukaka, who is the Director of Quality Management in the Digital Health Department, Ministry of Health and Population in Malawi. And the third presentation will be experience from health workers in Nepal delivering obstetric care in Kathmandu Hospital, which has a dedicated COVID-19 wing. This will be given by Dr. Abak, who is a consultant and obstetrician gynecologist at Dukel Hospital, and she's a professor at Kathmandu University, Nepal. And as Benny said, you will have a chance to ask experts questions. And in the meantime, next slide. In the meantime, what we ask you to do is you will type your question and target it to the specific speakers, and then we will get back to you. So now, Dr. Lenkat, the floor is yours.
Thank you, Dr. Tajbab. Good morning, good afternoon, good evening to those of you who've tuned in. It is my pleasure to share with you, as a way of setting the scene during this session, the results of our global study of maternal and newborn health provision during the COVID pandemic, which we call MATCO. This is the work of a large number of research partners across the globe. And the objective of this work is to understand how maternal health professionals and health facilities prepare and respond to COVID in regards to the care that is provided to women and their babies during antenatal, intrapartum, and postnatal care. And the work that I want to share with you today is based on two pillars of this study, one of which is repeated rounds of a cross-sectional global online survey, and the second one of which is the in-depth study of 7 referral hospital maternity wards in sub-Saharan Africa. So to tell you a bit more about the global online survey, it has been run twice now, and it encompasses 4 dimensions. Preparedness in terms of information, guidelines, training that is given to health providers, the response, such as screening of patients, testing availability, personal protective equipment, cleaning schedules, etc. The experience of health providers themselves, and then the adaptations or changes in the care processes, and the use of care that health workers are experiencing. Round 1 ran from March until July, in 13 different languages, and we've collected responses and testimonials from around 1,500 respondents from over 100 countries. And round 2 is available now since early July, and has so far had over 1,000 responses from 70 countries. Most of the respondents are either midwives, nurses, or obstetrician gynecologists, as you might imagine, based on the target population. So what I want to start with is a brief quantitative overview of what we are seeing. And of course, this is not a representative survey, but in round 1, approximately 1/3 of respondents responded that they feel either well or completely protected from COVID. As of now, from the round 2, we are seeing approximately 40 to 50% saying that. So this is quite suboptimal, really. About 40% of the more recent responses are saying that they are able to change personal protective equipment between patients. And also 40% are saying that their facilities or their care processes are requiring their patients to purchase and bring their own personal protective equipment, such as masks for women who are coming for antenatal care, for example. And on the more recent survey, we've also asked whether healthcare workers are able to access the SARS-CoV-2 test, and most of them are saying yes, and the vast majority of them are able to access the test for free. What I want to tell you a little bit more now is that there are issues, of course, respondents are mentioning beyond PPE. And PPE encompasses a huge amount of issues, including the availability and the quality of this material. Of course, there is training, manuals, but also there need to be skills training, simulation and drills, which is a gap that respondents are mentioning. It takes time to don and doff this equipment, and it has a cost to providers. In many settings, healthcare providers are reporting having to purchase some or all of this material from their own pocket. But if we center on the healthcare providers in maternal and newborn care, they also live in a multidimensional environment. And I wanted to talk to you about 3 of those dimensions. The first one being their team, their facility or working environment, and that is nested within the larger healthcare system, and the exposure to SARS-CoV-2 goes both ways. So within the team, the provider and the team. And the main issues mentioned by respondents here are issues of hierarchy. PPE is not accessible, available to all cadres, all wards, all facilities equally. And I think here we also have to mention the auxiliary staff, such as cleaners and laboratory workers who might, in some settings, be excluded. The ever-changing guidelines that are very hard to keep up with for providers. Issues of dual practice when perhaps providers might be working in both public and private sectors, and the increased risk of transmission that occurs when those practices continue. And healthcare workers are worried about their own testing, about their own infection, and how perhaps their illness, their absence will be handled within their working environment. The second dimension is that healthcare workers are coming into contact with patients, and patients have families. And again, here we have both ways, the exposure and the risks. So the concerns of healthcare workers in this regard include that in some settings, patients and their families are perhaps not able to comply with measures that protect the healthcare workers when they come in contact with patients. The healthcare workers are also worried about the cost of PPE to the patients. And the nature of contact, especially in maternal and newborn child health, the nature of contact between healthcare workers and their patients have changed dramatically. Healthcare workers are reporting that they have less time for patients. There is less face-to-face contact. Women are, for example, being discharged faster after childbirth. There might be more virtual communication, and that impacts the well-being of healthcare workers, of course. And the third and last dimension is that healthcare workers have their own families and live in their own communities. And the exposure perception here goes very much in one direction. And it is that the healthcare workers fear that they're being perhaps stigmatized, they're being cast as possible disease vectors because they are in this environment that exposes them to the virus. So there is a dichotomy where they are cast as heroes, but also as potential threats to their families and communities. They face stigma, sometimes violence, and of course there is an environment of rumors and myths and lack of facts in some of those communities. So this really puts a lot of stress and psychosocial issues on the healthcare workers that we are going to explore now in a much more local, country-based experience facilitated by our other two speakers. So what I'd like to do now is hand over to Dr. Andrew Likaka from the Ministry of Health and Population in Malawi.
Benna, we cannot hear.
Okay. You should be able to hear now. Apologies.
All right. Good morning and good afternoon, good evening, wherever you are. I'm Dr. Andrew Likaka, Director of Quality Management and Digital Health in the Ministry of Health in Malawi. And this time I will be presenting on perspectives of healthcare workers in delivering quality of essential maternal, newborn, and child health services during COVID-19. Briefly, I'll start giving you an update of the situation of COVID in Malawi as of 31st of August 2020. Malawi reported its first case on 2nd of April, and as of 31st of August 2020, we've had over 5,000 cases. Out of this, we had reported 37 confirmed pregnant women, 1 maternal death, and 1 woman who delivered successfully. Health services during COVID-19 have been disrupted, especially at MNCH, and this has been due to delays in health-seeking behavior among women. Mostly fears contributed highly to health-seeking, a delay in health-seeking behavior. Women were fearing that they will contract COVID in our health facilities, so they were attending late, or they couldn't even come to the facilities. Also, unavailability of healthcare workers as a result of protests that were there in some facilities. They will lead to closure of the facilities, and services will not be available, as well as the shifts that were introduced. At times, women will come and find out that the expertise are not there to provide the services. We've also seen an eruption in terms of a spike in teen pregnancies, as well as early marriages. Some districts have reported over 5,000 teen pregnancies in 5 months. Others even 2,000, for example, data. We've seen also increased attendance, decreased attendance for family planning services, and some facilities have reported even a decrease by 50%. We've noticed the general trend of decreased attendance at antenatal services in Malawi. Healthcare workers have been facing various challenges. Some are systematic, others related to the facility. Of note is the stigma and discrimination, where healthcare workers were discriminated against, some in public transport, others were being evicted in their houses. When they are renting, people in the community were thinking, you know, these are carriers of COVID, or they are bringing COVID in our community. Also, we've noted the challenges with the availability of guidelines as well as policies. With the ever-changing nature of COVID-19, we found out that when a policy is developed at national level, when these policies are deployed to implementation level, it took time, and even at the time when these policies are available and guidelines, maybe policies have already changed, or guidelines or protocols have changed at national level. And in some cases, healthcare workers were working without these protocols. We've seen also inadequate skills among newly recruited health personnel. As government has been responding to COVID-19, we recruited over 1,000 healthcare workers. Unfortunately, they were deployed without adequate skills before the deployment. We've also, healthcare workers have been feeling isolated due to the nature of COVID, and even some of their, because of being in contact with COVID-19 cases, as well as working in treatment centers. Some have been in isolation maybe for 14 to 21 days. And this has been really a problem or a challenge to healthcare workers. We've seen healthcare workers also protesting because of inadequate personal protective wear. We've had the infrastructure that could not adapt to COVID-19, especially delivery suites were not adapted, and they couldn't cope with COVID-19. We didn't have any suitable theater for a woman, for example, a pregnant woman who had COVID initially, so we had to work out on infrastructure. This was really a big challenge, and it's still a challenge up to date. We also had challenges in terms of access for mental health services. We've had inadequate support for mental health services for healthcare workers, especially those with stress and depression due to COVID-19. We've seen deaths amongst healthcare workers. 2 healthcare workers have died so far, a medical doctor and a nurse, and over 700 healthcare workers are infected with COVID to date. How has the system been coping and adapting? So social distance and mandatory use of face masks has been a key in all public facilities as well as private facilities in Malawi. And patients are always encouraged now to use face masks. It's a mandate that patients should be in face masks. Government recruited over 1,000 healthcare workers, as I've indicated, and they were deployed as a response to COVID-19. This was in June. Also, we recommended the congestion of health facilities by suspending elective cases. Most of the gynecological cases were essentially suspended. Some were returned from facilities. Though this was also the positive in reduction numbers of infections, but unfortunately, it created a delay in women in accessing quality of care. There have been also modification in the way health workers have been conducting services in order to maintain continuum of care and services. Healthcare workers have been encouraged to work in shifts. So we had rotas changed so that in an event that one shift is infected, another shift can still carry on and services will continue. We've also adopted innovation and technology in maternal newborn health. So we took also COVID as one of the cases to look into as among the near misses. So with support from Gates Foundation, through Wellcome Trust in Malawi, we've introduced a project that is running across all health facilities in Malawi, and we are using we've digitalized the tools for near miss as well as maternity registers. But this is helping to get real-time data and reporting on near misses. We've also introduced continuous development, continuous professional development among healthcare workers, where there is a peer-to-peer learning on a weekly basis, and this is supported by professional associations, College of Medicine, as well as the Ministry of Health. Communities are being engaged on a regular basis to ensure that there is a positive mindset change and their perception on healthcare workers change so that they can adapt and cope to live together. Also, we've seen the awarding system where healthcare workers who have worked on the forefront of COVID-19, some will be recognized. The president has introduced what is known as a ZICOM award, or thank you award, and this will be given as a motivation to healthcare workers on a quarterly basis. And there will be 5 identified according to a specific criteria that is going to be read on. Thank you very much, and I welcome your questions and comments. Thank you.
Thank you very much, Dr. Likaka. I am now going to start the presentation of Dr. Abha Shestra, who is a consultant obstetrician gynecologist from Dulikhel Hospital and a professor at Kathmandu University in Nepal. Please give it a few seconds until the video starts.
Namaste and very good evening to all of you.
Okay. Here comes the presentation.
I'm Dr. Abha Shestra. I'm professor and consultant in the Department of Obstetrics and Gynecology in Dulikhel Hospital, Kathmandu University Hospital. Today, I'll be talking about challenges in delivering obstetric care amidst COVID-19 in Nepal. All of us are very aware of the fact that healthcare workers are crucial to any healthcare system. Especially during the ongoing COVID-19 pandemic, healthcare workers are at a substantially increased risk of becoming infected with severe acute respiratory syndrome, that is, with coronavirus too. When I have to talk about the situation in Nepal, as many as 183 frontline health workers have contracted the novel coronavirus disease in Nepal. It includes 60 women and 123 male health workers. And these are the statistics that you can see on my slide from the different provinces of Nepal. I myself, being a health personnel, I can understand how another fellow feels. So these are the things that I want to basically talk about. The perception of risk, the need for PPE, the concerns for health and well-being of our loved ones, and how community perceives us. So the perception of risk. Risk perception is a subjective judgment of a health worker's belief about potential harm. Healthcare providers feel that their occupation places them at a higher risk of contracting COVID-19, while many nurses and doctors feel that their place of employment puts them at greater risk of contracting the coronavirus. They also feel that the public's failure to follow protocols put frontline workers at risk. They feel that the general population are not following the transmission guidelines such as social distancing, washing of hands, putting on masks, etc. And many healthcare professionals also feel that their underlying health conditions put them at risk of contracting COVID-19. As all of us are aware that those people who have comorbid conditions like hypertension, diabetes, etc., puts them at higher risk of contracting COVID-19. And most of us might have those diseases. As all of us are aware of the fact that if we put on PPE properly, it reduces our risk of contracting the disease when we are looking after patients with COVID-19. But in day-to-day practice, healthcare workers feel that they do not have adequate PPE, which puts them at a risk of contracting the disease. And many healthcare workers also feel the need of having a full set of PPE. Sometimes eye shields are missing, sometimes the goggles are missing, sometimes the gloves are missing. So they feel that they need full set of PPE to work properly. Some also feel that incorrect knowledge of the use of PPE in some clinical situation puts them at a risk of contracting the disease. For instance, they need proper training for doffing and donning of PPE. Many healthcare professionals feel the need for environmental controls like eye shields or goggles and gloves. And many healthcare professionals are not confident in their ability to correctly use the PPE. So they constantly feel the need of proper training for doffing and donning of PPE. Many healthcare workers feel that their lack of confidence is mainly due to unavailability and inaccessibility of PPE. And they feel that if they have this, maybe they'll be more confident in managing cases with COVID-19. Many healthcare workers are extremely concerned about the health of their family members and their own personal health. Many are concerned about passing the infection to their family members, especially after working in the COVID wing. They have this extreme fear of passing the infection to their family members if they are infected. And many have experienced severe psychological distress because of this. I remember one of my colleagues asking me, do you think we should go back home or do you think we should stay back in hospital? So these are our concerns when we look after patients with COVID-19. We all live in society. We are social beings. But of late, we are seeing incidences of people in the community not behaving very well with the healthcare workers. They perceive healthcare workers as potential source of infection. So after working long hours of duty, there is a problem as to where to go back. Many healthcare professionals feel very sad and depressed with the way they have behaved. Recently, there has been one incident in Nepal where the place where the healthcare worker were living were surrounded by community people, and they wanted them to leave that community, which is very unfair. Where I work, the Unical Hospital has been declared as the hub hospital of COVID-19 in Nepal. Pictures of the Unical Hospital. The government of Nepal has also declared the Unical Hospital as a testing site for COVID-19. We were decided as dedicated COVID-19 hospital for Nepal. We will get cases suspected and confirmed with COVID-19 infection. So we had to prepare ourselves. So we formed different teams comprising of 6 to 7 members in each team. And the teams were rapid response team, triage assessment team, fever clinic team, teaching and learning simulation lab team, information dissemination team, and contract tracing team. Each of us had posting in the COVID wing on rotation basis, and the staff who were posted in COVID dedicated hospital had PPE, different materials for the safety, training and simulation, and proper doffing and donning training. These are some of the things like personal protective equipments, the plastic wrap, where the chairs are placed. These are certain things mainly to make the staff feel more safe who are working in the dedicated COVID wing. Different materials which were made available, like sanitizers and different triage guidelines, and how to go for quarantine and when to go for quarantine. There are different guidelines which were made. The dedicated COVID wing to take care of COVID positive or suspected cases in Dhulikhel Hospital. We chose this building particularly because it was more isolated than the other wings in the hospital. And this is mainly for the safety of the patients as well as for the safety of the staff. These are the pamphlets which shows the different simulation courses that we conducted for the staff who were posted in the COVID wing. What I feel is there should be institutional strategies, and these strategies should be very clear as to support and appropriately manage the exposed and infected healthcare workers, because it is essential to ensure effective staff management and to generate trust in the workplace. And there should be treatment support like ICU care and ventilator support to the healthcare personnel when they become symptomatic. We have seen that there has been lack of trust from the public part towards the hospital and the people working in the hospital. So it lies on the behalf of the policymakers to make policies to make the public believe that they are less likely to get infected from the health personnel. And for this, adequate amount of PPE and proper training of the health personnel is required. Policymakers need to support healthcare facilities in interpreting guidance during a pandemic that will probably be characterized by fluctuating local incidence of COVID to mitigate the impact of this pandemic on their workplace. Thank you very much, and Dhanyabad. This is the end of my presentation. I'll be very happy to take your queries and questions. Thank you once again.
Thank you very, very much, Dr. Shrestha. I am now handing over again to Lenka Benova to start the question and answers. And I see that we've got quite a few questions already from participants. Lenka.
Right. Thank you so much, Bene, and thanks for the lovely discussion that is developing in the chat. Please continue that and we'll take your questions. I think just to wrap up those two excellent presentations from our colleagues in Malawi and Nepal, I just wanted to highlight some of the issues that are in common, one of which is psychosocial issues that are quite urgently in need of being addressed, but not just in low and middle income countries, also in high income countries, we are seeing those issues come up. And not surprisingly, this is coming from many different reasons, such as lack of support, exhaustion, powerlessness. But I also wanted to make sure that we realize that healthcare workers are very upset about the suboptimal care and experiences for women and babies. And this is an example of this could be, separating newborns from mothers, inability to provide breastfeeding, counseling. Women are not able to bring along birth companions. And this affects healthcare workers hugely. One of the things we are asking providers is, what is some of the positive changes? What are some of the positives that COVID has brought? And 3 issues come up very frequently. One is emphasis on hygiene. And this has been an issue for decades now, and it's finally seeing the rightful recognition. So for example, sinks, hand washing facilities are being brought closer to points of care, which is an excellent move. More training and more skill building is being provided to healthcare workers. And there is more team effort, and communications have moved from face-to-face meetings, closed meetings, to virtual settings where more providers, more team members can be included. What can be done better to support you is the last question that we asked on the survey. And I've listed the top 7 that come up in the order of priority. I'll run through them very quickly because you can see them, but better availability of PPE and training, enhancing testing capacity, better transportations for healthcare workers, provision of mental health support and psychosocial counseling, the need for unified guidelines and at national level and clear communication of these guidelines to facilities and health workers, provision of financial incentives, rewards, motivations for healthcare workers, and increased awareness of safety measure among the public, which is one of the big points that Dr. Shrestha also highlighted. I will leave my presentation on the note. Some of you have asked whether you could have the questionnaire. The questionnaires are available. I put the link here on the study website, on the ITM website. I've also pasted it in the chat. Please get in touch with us if you'd like to collaborate, or if you'd like to know more about your particular country's findings. And if you are able to disseminate the survey to more providers, we would be very grateful. So what I'll do now is start officially the Q&A session. Please continue to use the chat window to ask your questions. I will perhaps start with a question for Dr. Likaka. That came in at the beginning, whether adequate PPE for support service workers, such as cleaners, are readily available, and whether they're provided training and ensuring proper follow-up and skills. Would you mind taking that question, Dr. Likaka, please?
All right, yeah, thanks very much, Bennett, and thanks all colleagues. Yeah, I think the first challenge that we noted when COVID came on the scene was knowing the right PPE for which place. So I think that really became a big challenge. Everyone thought that I think the PPEs should be the same for every cadre and every place where people are working. It's still up to date. I think that hasn't really gone through everyone's mind that there are specific PPEs for specific roles and places. So we had to define that. For example, what type of PPE should be done by supporting staff? What type of PPE should be done by frontline staff? And for example, people working in OPD or people working in the ward, what should be the case? So definition alone helped us to make sure that we categorized and we mobilize necessary PPEs for each cadre. So support staff have got PPEs. We provide PPEs to all direct healthcare workers as well as cleaners based on where they are working and based on the roles that they are undertaking.
Great.
Thank you very much, Ben.
Thank you very much. Dr. Abba, I will turn to you next. The question is, have you had healthcare workers at your hospital who have refused to come to work? And how have you handled that situation? So if they've refused to come to work due to fear and concern about contracting COVID?
Thank you, Benny. We haven't had such a situation so far, but there is a constant fear of contracting the disease, especially when people are posted in the COVID wing. And there has been a lot of psychological stress when people are posted there, because they're very scared of contracting the disease. And the very fact that after the posting, they need to get themselves tested, and if they are positive, they had to go for isolation and then quarantine. All those issues always keep them quite disturbed. But so far, we haven't had any staff saying that we will not like to come to work because of fear of COVID.
Great.
Thank you.
Thank you. And the next question is actually for both of you. It is about the stigma and social stigma against health workers. I'll ask Dr. Likaka to comment first. Have you had any successes in addressing the community level or stigma against health workers in Malawi?
Yeah, so thanks very much, I think, for that question. Essentially, I think one of the success stories has been the change of dressing code. Mostly we find nurses and clinicians putting on their uniforms, even in public places outside the hospitals. So when we noted that there was a lot of stigma in the public space, public transportation and the like, we had to put up a policy to ban use of uniforms outside the normal working places. And that has helped a lot because no one, at least in all of them. The other area was engaging the community. We had so many cases that people were evicting healthcare workers. So we had to engage leadership, like members of parliament, senior chiefs, to address their communities. And eventually that worked. Yeah, we've seen a lot of improvement in terms of stigma from that aspect.
Mm-hmm. Great, thank you.
Yeah.
Dr. Shrestha, would you like to comment on that question of stigma from your context, please?
Thank you, Benny. Yes, as I told in my presentation, we had one incident where the health workers who were staying in one of the places, the community did not like them to stay in that place. And that was something very disturbing. But apart from that, we haven't had such kind of incidents, but that was taken very seriously by the different chief district officers of Kathmandu, and they had strictly said that this is something which is not very nice to do, because the health workers are the ones who are the frontliners, and they are the ones who are actually fighting against the disease for all of us. They try to bring up issues that healthcare workers are someone who is very important, but still I don't know how community are going to perceive that, because we had one incident, and that's very traumatizing to all the healthcare workers in Nepal. And many issues have come up after that, saying that none of the healthcare workers should be stigmatized the way that it was done, and they should be respected. So I hope the community feels that, and they respect that feeling.
Great, thank you. The next question, we are getting a broad range of questions, and many of them apply to both of you. So I'll do that. I'll ask you both to comment. The next theme that is coming through the chat is issues of psychosocial assistance to healthcare workers. Dr. Likaka, can you share a bit about how you're able to provide support to healthcare workers along psychosocial or counseling issues?
Yeah, yeah, thanks very much. I think this is one area that as a system we are lagging behind. We just believe in peer-to-peer support, but no formal system has been set up. And this probably links to how mental health services in our communities are almost left out. We have limited the support in terms of capacity. We don't have many psychologists in Malawi. Even I think we have 2 or 3 clinical psychologists against the population of 18 million. It's an area that needs to be developed. So at the moment, we rely on peer-to-peer counseling, peer-to-peer and family support, but I wouldn't comfortably say that it's an area that we've developed much, and there are lessons that I can share. Thank you.
Thank you. And Dr. Shrestha, from your perspective?
Thank you, Benny. As I said, it is so much of psychological stress when we are posted in the COVID wing. So I can understand how the health workers feel here in Dhulikhel Hospital. And we have this internal system of addressing that. We have psychologists and the psychiatrists. So they are available online, and also whenever we need in person, they are available in OPDs also. But when you talk about whole of Nepal, I don't think that facility is available in all the hospitals where the government has chosen as a COVID hospital. So like Dr. Andrew said, we need peer-to-peer support and also support from the family in order to maintain the psychological health of the healthcare workers. Thank you.
Great, thank you so much. Another common theme that is coming up is whether maternal newborn workers, particularly midwives, have been in your countries or in your facilities assigned to other wards or to COVID wards specifically, and what has been the implication on staffing of that move. Dr. Likaka?
Yeah, thank you. Yeah, so initially, I must indicate that healthcare workers were afraid to go to treatment centers. We had to come out with mechanisms to motivate them. One of the mechanisms was that if you work in a treatment center, you get, you'll not be staying, you'll not be going at home. We'll find a better accommodation for you. We'll be giving you food, as well as we'll be giving you a daily subsistence allowance. Because you are away from home, but you have to stay for 7 days, then you stay again for 14 days in isolation. We noted that because of those shifts, and initially the guidelines were pure isolation, so we had to arrange a shift. We had to have 3 teams of almost 13 people in each shift. So that created lots of gaps. The other thing is that some of the cases needed specialist care, and we have few specialists. So if you get a specialist into that team, it means this specialist is out for almost 21 days. So it created a lot of little gaps in many wards and many facilities. With time and changing guidelines, also with the change in terms of the numbers of admission, the situation is becoming better. We are moving into integration. There are lessons that we've had over the previous 6 months that we are trying now to integrate COVID management into the normal routine care. But I must indicate that COVID has affected, as I've already indicated, it has affected a lot. Mostly maternal and newborn services, even women who had other problems that are not emergency, they are still waiting. Cancer patients are still waiting. So ethically, and I think really COVID has had a big impact negatively on the health system in general. Thank you.
Thank you. And Dr. Shrestha, have you faced the same issues with staffing if maternal health workers had been reassigned?
Yes. What we have done is the healthcare workers, they need to self-isolate when there is a suspicion of infection to prevent transmission. And our hospital has different isolation areas and quarantine areas for the staff. And to continue with the provision of care, we have made 3 to 4 groups in each department. And each group will have about 5 to 6 members who will work for about 4 days. And then they are off for next 7 to 10 days. This is mainly to prevent exposure of infection to all the faculties and at the same time. And suppose a group gets infected, we still have other groups to replace them such that the continuity of care is not hampered.
Great.
Thank you.
Thank you. Dr. Abba, the next question is also for you. Can you share with the webinar participants how in your facility you are handling the disposal of used PPE?
Yes, we have a proper channel where we have this doffing and donning. It has to be done properly, and we have this proper channel of disposing the PPE and the waste from the COVID wing itself. So it is not. It has a completely different channel compared to the other wings of the hospital. So there are specific team members who look after this, and then it is mainly to prevent transmission of the disease to the other side of the hospital, such that other people are safe. Thank you.
Thank you very much. Dr. Likaka, a question for you. How have you found useful to manage and communicate the changing guidelines to healthcare facilities and healthcare workers in Malawi?
Yeah, that has been a very big problem. Looking at, first of all, the fact that most of the health workers are in rural areas where communication is a challenge. And also the COVID-19 is a strange phenomenon. So most of the times when what we did is to cascade development of the guidelines, engaging various levels. So whenever there are new guidelines that need to be developed, first we make sure that we have representatives from districts, representatives from zonal level, representatives from national level, representatives from various associations, professional bodies, as well as even community members. So we utilize this sector, believing that immediately we agree, they will help also to disseminate. The other area is we've decided not to be printing the guidelines because changes are coming more often. So with the move to digitalization, the plan is to digitalize most of the guidelines so that when there are updates, we just update accordingly. We've used Zoom calls. We have regular Zoom calls on a weekly basis where we share also guidelines that have come in. But I must acknowledge that most of the information ends up at the district level, where connectivity is better than in rural peripheral areas. So it's the responsibility of the district level to move out to rural areas. Now, with the limitations also to move because with COVID-19, we've minimized movement. That has really affected the way guidelines and policies have been adhered to at the local level, especially in the rural areas. I saw someone was commenting that people are not putting on face masks, mainly the community. So the picture that I sent there was an odd one. That's before we came out with a policy. But now all patients, it's mandatory that patients should have face masks, and people seeking care should have face masks. So it's mandatory now. Thank you.
Great, thank you. And actually, you've raised another important point, which is coming through in the questions, and that is sort of the virtual connections, communications, whether it is training or team and staff meetings, Zoom calls. Dr. Shrestha, can you comment on how effective phone calls, Zoom, and in general internet connectivity is in reaching all healthcare workers in Nepal?
Thank you, Benny. Yes, we have these different guidelines from everywhere, from WHO, from RCUG, ACUG, and our own society guidelines. And we have to update them as and when needed and as per need. And in our department also, we have made a protocol when COVID just surfaced up in Nepal. And we update that as and when needed. And we share it in our group through Viber or WhatsApp or Zoom meetings. And then when we need to reach the community, we have the same modalities of reaching them. But we have to consider that the internet connectivity may not be very proper all the time. So in that case, it becomes a difficulty, and that's one of the challenge for us. But in Nepal, we have this good connection of telephone in many places, and this is how we try to reach our healthcare workers in the community and even in the hospital.
Great, thank you. I think we have 1 more minute, so I'll take one more question, which both of you hopefully can respond to quite quickly, and that is on financial incentives. Are you able to provide financial incentives for healthcare workers, and how is it working, if so? Dr. Likaka?
Yeah, so I think I responded in the chat. Thank you on that. We are providing financial incentives, risk allowances to all healthcare workers. But I must say that it's not sustainable. Districts are struggling to manage that. And other government sectors are now demanding similar incentives. And so it's not really sustainable. I think what is sustainable to me is making sure that healthcare workers are working in safe spaces, they have PPEs, and they feel supported. I think that is something that is sustainable.
Great, thank you. And Dr. Shrestha, to finish with the Q&A?
Yes, thank you, Benny. The government of Nepal had actually said that there will be incentives for the frontline healthcare workers, but I don't think that has been fully implemented in Nepal yet. But the assurance that, we will be taken care of if we contract the disease, like when we need ICU support and ventilator, if it is there, then it's one of the things that is more assuring than the financial incentives for the doctors. Thank you.
Great. Thank you both. What I'll do is now hand over to Dr. Blerta Maliki from the World Health Organization. Thank you.
Colleagues, thank you very much. Thank you, Dr. Lenka Benova. Thank you, Dr. Andrew Likaka. Thank you, Professor Haba Shrestha. Going forward, we'd like to draw your attention in 2 important guidance that are in relation to maintaining service delivery during the COVID pandemic. You will receive that as part of the presentation. Next slide, please. We would like to announce that you can see the webinars that you just attended in our YouTube channel. You are invited to register in the community of practice, in which we'll answer all the questions that were logged during this conversation. And we would invite you to join us in the conversation around quality care and health for all. Thank you to all panelists, really appreciate it, and looking forward to reconnecting with you in the next webinar.
Thank you.
Oh.